welcome you all to our today's session on how to use evidence-based medicine. And as you know, we have been running this program from the very beginning of COVID. We started with breast cancer. Now we are running the session on lung cancer. So today we have a speaker, Dr. Mostafa Aziz Sumon. He will be talking on the adjuvant therapy in early non-small cell lung cancer. And today we will have a case discussion where Dr. Arman Reza Chaudhary will do the case discussion. So now, before that, I want to request our President, Professor M.A. Haisa, to formally start the program. Then we will go to our presentation. Sir.
Rahim. Heartiest welcome to all of you. And I think we should not delay. Already we are 5 minutes late. Let us start immediately. Let's go on, start your lecture.
Thank you, sir. Thank you. I'm Dr. Mostafa Aziz Sumon. Today, I will try to cover adjuvant therapy in lung cancer. So first, you can see this is a very interesting paper. It was, oh, sorry. What is happening? So this is a very interesting paper. You can see that the UK group of people, they find this, that during the last 40 years, the development in total oncology, you could see that overall 25 to 50% improvement was achieved during this last, what is happening over there? Sorry for the introduction. I don't know what is happening. Probably there is some virus issue.
So তাহলে কি যে
ইমেইলে মিক্সার
করবে
আই ক্যান শেয়ার
এটা পাঠিয়ে দিবা
আমার মনে হয় একটু পাঠিয়ে দিই, কারণ আমার এখানে বারবার স্ক্রিনটা চলে যাচ্ছে।
হ্যাঁ, তুমি ইয়েকে পাঠিয়ে দাও, সমীরকে পাঠিয়ে দাও, সমীর শেয়ার করবে।
ওকে,
করোনা ভাইরাস নাকি?
আমি জানি না স্যার।
স্যার এটা ট্রোজান ভাইরাস স্যার।
সমীর,
স্যার
আমি তোমাকে পাঠিয়ে দিচ্ছি, দেখো।
স্যার স্যার এখনো আসেনি স্যার।
তো সেট দেখাচ্ছে আমার কাছে, তুমি দেখো তো।
নট ইয়েট স্যার, আমি রিলোড করলাম, নট ইয়েট স্যার।
এখনো পাওনি?
No, sir. Not yet, sir.
সুমন ভাই,
হ্যাঁ
আমাকেও পাঠান তো মেইলে।
সমীর, তুমি পাওনি?
No, sir. Still not.
এখন
Still not, sir. এখনো আসেনি, sir. Gmail এ একটু ঝামেলা করছে, স্যার, মেবি, স্যার।
সুমন, আমার কাছে যেটা আছে সেটা আমি ফরওয়ার্ড করছি। হ্যালো,
স্যার, আপনারটা পেয়েছি আমি, স্যার।
আচ্ছা, তুমি এটা শো করো, আমি এটা দিয়ে প্রেজেন্ট করি, অসুবিধা নেই।
সুমন, আমারটা দিকে শুরু করবা, তারপরে ওইটা
হ্যাঁ, শুরু করেন,
তোমার তো
শুরু করেন।
লাস্ট স্লাইড তো মিলবে না, লাস্টের দিকে তো স্লাইড মিলবে না।
স্যার, আমি শেয়ার করছি, স্যার।
সুমনেরটা পাইছো?
আচ্ছা,
স্যার,
আরমান,
আপনারটা পেয়েছি, স্যার। আপনারটা পেয়েছি, স্যার।
কামাল ভাই একটা কাজ করুক, আরমান কেস প্রেজেন্টেশন শুরু করুক, আমি বাই দিস টাইম রেডি করি।
হ্যাঁ,
আরমান কেস প্রেজেন্টেশন শুরু করুক।
কেস প্রেজেন্টেশন শুরু, তোমারটা কি আবার পাঠাতে হবে নাকি?
আমি পাঠাচ্ছি, আমি এর মধ্যে পাঠাচ্ছি, আরমান শুরু করুক, ফুল এর মধ্যে আমরা সেট করে ফেলতে পারবো। আরমান শুরু করুক।
ওকে,
Should I stop sharing, sir?
হ্যাঁ,
এটা এটা কোনটা? এটা কি আমারটা?
এটা কি কামাল ভাইয়েরটা? তুমি নিচে যাও,
Yes, sir.
একদম
Yes, sir.
লাস্ট স্লাইডে যাও তো, লাস্ট স্লাইড, একদম লাস্ট স্লাইডে যাও। হ্যাঁ, ঠিক আছে, এটা প্রেজেন্ট করো, অসুবিধা নেই, করো।
এটাই করো, এটাই করো।
হ্যাঁ, করো, সমস্যা নেই।
Okay, sir.
কারণ ও কেস করলে সিকোয়েন্স থাকবে না, তোমার প্রেজেন্টেশন
হ্যাঁ,
থাকবে।
ঠিক আছে, তুমি ফার্স্ট স্লাইড থেকে দাও, অসুবিধা নেই। ফার্স্ট স্লাইড দাও,
Yes, sir.
হ্যাঁ, এরপর সেকেন্ড স্লাইডে যাও।
ওকে,
Sorry for the interruption. I really don't know what was happening there.
Sir, I'm giving you remote control. You can change the slide.
No problem. You just like you just change the slide. I don't know, my mouse, my keypad is not working properly.
Okay, sir.
So here you can see that the last 40 years, the total development in oncological outcome in UK, and you could find that overall there is 25% improvement in all cancers, but unfortunately, the lung and pancreas are the lowest number. So you can see the development is not so far. So there is a great space to improve on lung cancer management. So we need to focus on the adjuvant therapy. As you know, that the main treatment is surgery for lung cancer management. So there is a great role for this adjuvant therapy. And as you know, that the adjuvant therapy, we do have chemotherapy, radiotherapy. These are our old trusted weapons. But beside this, there are now two new weapons, that is the immunotherapy and the TKI. So in my next 20 minutes lectures, I will try to cover all these adjuvant therapy, chemotherapy, radiotherapy, immunotherapy, and role of TKI. Next slide, show me. Show me next slide. So you could see that there are around 80% recurrence occurs within 2 years, particularly for uh, early lung cancer management after this surgery. So you can see that the 80% recurrence. So there is a great role of this adjuvant therapy to decrease this number. Next slide. So this is the first published 1995 BMG meta-analysis. This is the basis of the adjuvant therapy in lung cancer management. And here you can see that these meta-analysis, including around more than 4,000 patients, and you could see that the alkylizing agents cause detrimental effect, less than 5%, 5 years overall survival, less than 5%. And you could see that the cisplatin-based chemotherapy, the 5-year survival rate is more than 5%. So this was the basis of this adjuvant therapy. From this meta-analysis, the scientists focused on this adjuvant therapy regarding on chemotherapy. Next slide. So after this was published in New England Journal of Medicine in 2014. This is the International Adjuvant Lung Cancer Study. You could see that there is the number of around 1,867 patients, and they included stage 1 to 3. Cisplatin-based chemotherapy was given. And in this study, they found that at 5 years, the absolute survival benefit was 4.1%. So with cisplatin-based chemotherapy, they could find that 4.1% survival at 5 years. Next. So that the 5 years overall survival, when came to a long-term follow-up, at 8 years, you can see that 8 years, the overall survival was not found. That was found at 5 years. Because those group who got chemotherapy, the non-cancer related death was more in the chemotherapeutic arms. So the overall survival that was found at 5 years was not found at long term. But the benefit of chemotherapy on recurrence still was maintained. So the ILT long-term study could not give us an idea the role of chemotherapy on overall survival. Next. So here comes this very good Xavier 10 study. You could see that the Xavier 10, here they include stage 1B to stage 2 patients, and they tried chemotherapy with vinorelbine and cisplatin. And here you can see that 5 years, the overall survival benefit was around 15%, and it was highly statistical significant. Next slide. So you can see here that the Xavier 10, though there is overall 15% overall survival, but here you can see that those group that was in 1B, you could see there was no difference between observation versus chemotherapy. So in Xavier 10, the difference in overall survival was mainly evident in stage 2 group. You could see that there is a long difference, where in the stage 1B, there is no difference. Next slide. So again, this updated JBR 10. So here you can see that 9.3 years follow-up. Still, the hazard ratio was quite significant for stage 2 disease, but it was not significant in stage 1B disease. You can see that including all patients, it was significant in long-term follow-up. Stage 2 patients, it is significant, But in stage 1B, you could see there's the crossover, that the observation is higher than this chemotherapy. So updated JVR10 shows that the chemotherapy definitely gives benefit in overall survival, even in long term, but it was evident only in stage 2 or more. It was not for 1B patients. Next. So here you can see that what we should do with this 1B patient. So the JVR10, they analyzed again, and they could found that the tumor, those who were less than 4 centimeter size, it was not a area of consideration. But those who were more than 4 centimeter, you could see there is a difference over there, and the hazard ratio is 0.66. And this hazard ratio is very similar to stage 2 patients, because in JVR2, in JVR10 study, particularly for stage 2, the hazard ratio is around 0.66. And here you can see that stage 1B, those who have tumor size is more than 4 centimeter, here ratio again here is 0.66. So, but it is not statistical significance. So from this study, we can interpolate that the tumor that is more than stage 2 is definitely will get benefit from chemotherapy, and those tumor that was in stage 1B more than 4 centimeter will get benefit from chemotherapy, but that is not statistical significant. Next. So to get an idea regarding this 1B stage, here comes the study CLGB 9633. Here they tried only 1B group patient, completely resected, tried paclitaxel carboplatin, and you could see that the 12% survival benefit at 4 years. But again, at 5 years, there is no difference. Next. So that the long-term data, the long-term follow-up at 9 years, the study remains negative. So there is no difference giving chemotherapy or not giving chemotherapy. Though there is a improved trend for chemotherapy arms, but it was not statistically significant. So CLGB fails to give any idea regarding the 1B status, 1B stage patient. Next. Show me the next. Yes. Here comes the ONITA study. That is the Adjuvant Naval-Win International Trialist Association directed study. You could see that here they tried 1B to stage 3 a patient. They have tried 4-cycle cisplatin plus vinorelbine. And it's a long-term study. You could see that the 7 years, there is a statistical significance around 8.4%. Next. So here comes this LACE meta-analysis. You could see only 2 studies statistical significant, that is the ONITA and the JVR10. And the combined all this study, you could see that the chemotherapy is better. Next. So after 2 decades of research, you can see that the 1995 BMG meta-analysis, you could see that 5% overall survival, ILT 4.1%, Xavier 15%, Anita 8.4%, LACE 5.4% overall, and those who have received cisplatin will 8.9%. So from this slide, we could see that adjuvant chemotherapy has a very good role for stage 2 onwards, and there is a role for 1B patients, those who are more than 4 centimeter tumor size. Next. So here now the question comes, what should be the chemotherapeutic regimen? So in my recent presentation, I have had one more slide, but it was missing there. So there are some retrospective analysis. They could try to find out whether cisplatin or carboplatin equal or not. So there are some retrospective analysis. They found that cisplatin comparable to carboplatin, but cisplatin and vinorelbine are the most studied regimen, because the 2 positive studies, that is JVR10 and ONITA, they have tried with cisplatin and vinorelbine. So carboplatin can be used when cisplatin is contraindicated. Next. So when to start this chemotherapy after surgery? So here you can see that the Xavier study, they have treat with chemotherapy after 6 weeks, ILT within 60 days. And there's a Canada registry. They have tried with observation 0 to 10 versus 11 to 16 weeks, and nothing difference was found. So we could start chemotherapy even after 6 weeks, but as early as possible, that would be the better option. Next. So here comes the guidelines, that is the ESCO guidelines. In ESCO guidelines, they have mentioned to give adjuvant chemotherapy starting from stage 2A up to 3A disease. 1B is not currently recommended. In NCCN, they have included 1B tumor, considered for high risk as if it is neuroendocrine, if there is vascular invasion, tumors more than 4 centimeter size. So in NCCN guidelines, 1B is considered for adjuvant chemotherapy. And the NICE guidelines, they are almost equal to ESCO guidelines, but here they also included the good performance status. So those who are having good performance status 0 to up to 1 WHO status, they should be candidate for adjuvant chemotherapy. Next. Before going to immunotherapy, let me summarize. So we need to memorize here only 3 studies. That is the Xavier 10, ONITA, and BMZ 1995. And we should remember this, that the overall 5% survival at 5 years achieved with chemotherapy, and we should give chemotherapy to any patients more than stage 2. And if we want to give chemotherapy stage 1 disease, the patients should have tumor size more than 5 centimeters associated with some poor prognostic factors. So and that is the chemotherapy. Now here comes the we are in the area of immunotherapy. What is the role of immunotherapy as adjuvant therapy? As we have already got some information from the Pacific trial, after giving concurrent CTRT, durvalumab has a good result regarding the disease-free survival rate. So why not to give the immunotherapy even after the complete resection? So we have to wait up to 2024, because in this PULSE study, after complete resection, even after adjuvant chemotherapy, they are going to enroll patients in 2 arms, 1 year pembrolizumab versus placebo, and let's see what this PULSE study is showing. So kind of till date, there we don't have any data regarding the adjuvant immunotherapy. Next. So here all about the chemotherapy, that the adjuvant therapy, you could, I have already mentioned that the 2 and 3 patients, stage 2 and stage 2 patients should get benefit from chemotherapy, and 1B tumor should be considered when tumor size is more than 4 centimeter. Older patients more than 70 years can tolerate chemotherapy, but very elderly patients 75 or 80 years, we need to check regarding their cost benefit issues. And there is another issue, that the selected chemotherapy like Primatrix or any other agent, whether they have any influence in the overall survival. So regarding all investigations, all studies, it is very difficult to say that if that the overall outcome is really dependent on any types of chemotherapy. Next. So here now I will discuss regarding our very old friends as adjuvant therapy regarding radiation therapy. So next. So there is a very old meta-analysis. It was published in 1998, and later on in 2005, you could see that 2,232 patients was randomized in 2 arms. One arm was surgery alone, and another was surgery versus post-operative radiotherapy. And you could see that the 2-year survival rate was 58 in the surgery arm, and the surgery in port arm 52%. So there is around 6% detrimental effect with giving radiation therapy. Next. So is there any place of radiotherapy after complete resection? According to the meta-analysis, answer was no, especially for those patients who pathologically N0 or N1 disease, and stage 1 and stage 2 disease, because this postoperative radiation therapy was produced cardiopulmonary toxicities. But the uh, radiation oncologists argued with some points that the dose was quite high, 54 gray, the daily fraction was more than 2 gray, large volume radiation therapy was given, very old technique was applied like cobalt or spinal cord blocking. So these were the points in favor for the radiation oncologist, and they tried to say that there is a role of radiation therapy, at least for N2 disease. Next. And they found some uh, factors that might get benefit from radiation therapy, as suboptimal or inadequate surgical resection, those were N to nodal involvement, extracorporeal capsular extension, and lymph node ratio. That is the number of pathologically lymph nodes divided by the total number of lymph nodes. And if there is a skip status, like if there is an N2 patients in absence of N1 disease. So there are some risk factors where the radiation oncologist considered postoperative radiation therapy. Next. So in favor of the radiation oncologist, there was some publication. You could see that without radiation therapy, there is the recurrence around 30%. With radiation therapy, you could see the McTay et al. It was around 11%, Keller et al. At 13%. So there is the recurrence rate 14.7 versus 28.9 with Port trial. So these were some paper that was in favor for the radiation oncologist. Next. Here you could see that the very famous ONITA trial. Here you can see that the 47.4% 5-year survival rate, those who have received radiation therapy after chemotherapy, with those who received no radiation therapy, that was 34%. So there is around 13% overall survival difference with those patients having radiation therapy. Next. So not only the chemotherapy, some tried to compare with CT versus concurrent CTRT, and you could see that after complete resection, in one arm only chemotherapy and another arm paclitaxel concurrent with radiation therapy. Next. And you could see that there was no difference versus chemotherapy versus chemoradiation therapy. So next. So till date, there was some arguments regarding the postoperative radiation therapy. The meta-analysis was not in our favor. So we could we tried to argue with some papers only, even for the N2 disease, that there is some role of radiation therapy. And we were waiting for this Langer trial. It was designed in the such way that after completely surgical resection, even after chemotherapy, only for N2 disease, one arm was in control and another arm was port. And this year, next. And this year, the Langer trial result published in the ESMO Virtual Congress. And here you can see that the completely resected stage 3A patient N2 disease was included in this study. Medicinal port given 54 gray in 27 fractions or 30 fractions versus no port. And all the radiation therapy was given with higher conformal technology. And you could see that 3 years disease, overall disease survival 66.4 with port and 68.5 without port. So still there is more overall survival for arm having no radiation therapy. Though the medicinal relapse was 15% reduced with port radiation therapy. At last, the authors declared that we can safely say that there is no net benefit from such treatment, but there is also potential harm, which we see from the study. So any potential benefits in some patients are offset by the predominant high risk of cardiopulmonary toxicities. So the area for N2 disease, where the radiation oncologist really focused on, that there's some role of radiation therapy. After the ART lung trial, we could say that there is no role of radiation therapy as adjuvant therapy, even in N2 disease, so we could offer only postoperative radiation therapy if there is a positive resection margin. Next. So here comes the new concept, that is the Adjuvant TKI. So after the Aurora trial, there is a good discussion, good conversation regarding this Adjuvant TKI. As you know, that we are searching for a good adjuvant therapy to increase our to decrease our recurrence rate. Here is the history. You could see that the BR19 and the Radiant trial, it was tried in very early 2000 to 2000 centuries. And you can see that after these, the Select trial, and after that, the Adjuvant and Adora trial. Next. Here comes the BR19 trial. You could see that after the complete resected 1B to 3A disease, the Zefitinib arm versus placebo trial, placebo was tried. And you could see that in this study, it was irrespective of EGFR mutation status. And they have included around 28% patients with this squamous cell histology. And eventually it comes with negative outcome. Next. After this, the Radiant trial, it was tried with erlotinib with similar type of patients, 1B to 3A, completely resected patients. And even still in this study, you could see that the EGFR mutation was not considered, and around 31% patients with squamous cell histology was included, and it was come with negative. But here you can see that when the interim analysis was done with the EGFR mutation group, there was a increased trend in overall survival. Next. So in the earlier trial, you could see that neither trial is positive, but there are some limitations because both of the trials not included the EGFR mutated patients. Most of the patients were EGFR wild types, and they also included 30%, around 30% patients were squamous cell carcinoma. So they failed to produce any survival benefit. Next. So here comes the Select, the first trial that show that included the EGFR mutation groups. And you can see that they completely resected stage 1A to 3 patients with EGFR mutations. And we tried with erlotinib up to 2 years. Next. And you could see that it was what is a phase 2 trial. So it was not a, there was not a comparable arm, but they have compared with the historical result. And you could see the 2-year disease-free survival was around 88% and significantly higher with the historical control around 76%. So it is the Select trial that gives a hope that the Adjuvant TKI might have a role in completely resected groups. Next. So after this Select, scientists became more enthusiastic, and here comes the Adjuvant or Setong trial. And after that, the Adora trial. Next. So Adjuvant or Setong trial, you could see that stage 2 to 3 patients after complete surgery, here they include N1, N2 disease. After the complete R0 resection, they randomized Zefitinib versus mineralbin plus cisplatin, the most trusted combination. And the primary endpoint was disease-free survival. Next. So you can see that the disease-free survival with this Setong, that the Zefitinib arm, the 3-year disease-free survival was 34 versus 20 chemotherapy 27, and the hazard ratio was 0.7%. And you could see that the disease-free survival is significantly difference between these two arms. Next. Next. So when the final result come, as the Adora trial, the Setong trial was initially very encouraging with disease-free survival, but when the final results came after 5 years, you could see that the no overall survival benefit with Zefitinib. We could see that the 75.5 versus 62.5 months and hazard ratio 0.92. So the disease-free survival that was evident with the Zefitinib in the long run failed to produce any overall survival benefit. So next. So here comes this Adora trial, that is that is mostly discussed, and it's a very higher rated publication. It was discussed in this year, and you could see it is the similar type of patient population. You could see that stage 1B to stage 3A, non-squamous EGFR mutation, only those with and deletion 19 or L858R mutation was included in the study. One arm in osimertinib, another arm in placebo. Next. So you could see that the 24 months disease-free survival is around 90% compared to 44. And you can see that the hazard ratio is 0.17. That is the amazing result. Next. So 80% reduction in risk of disease recurrence. Next. But that overall survival data is immature at the time of interim analysis. Next. Considering the CNS metastasis, 82% reduction in the risk of CNS. Next. So there are some adverse effects that is very comparable with osimertinib. Next. So recent data of adjuvant EGFR TKI in non-small cell lung cancer. You could see the disease-free survival was used as the endpoint in both the trial, adjuvant and ADAURA trials. So long-term impact of this data is still uncertain. Where you could see that the CTONG trial, it was produced a very good disease-free survival that failed to produce ultimately overall survival in long run. So we have to wait to mature data from this ADAURA trial to see whether it has really had impact on the overall survival. So next. So incorporating adjuvant EGFR TKI, we have to consider these issues, that the accessibility of particular EGFR TKI. Here in Bangladesh, we have osimertinib at a very cheaper rate, but that not might be the consideration for giving this EGFR TKI, because we don't have enough data to practice, to change our practice right now, as because the long-term data are still lacking, and we should really know who are those group patients that are really going to get benefit from this TKI. Next. So regarding this TKI, we need to consider these things, that right now, no guidelines recommend EGFR directed TKI for early stage non-small cell lung cancer, because the impact of EGFR mutation status on early stage disease biology is still unclear. Initial EGFR TKI in adjuvant setting failed, and even the CTONG trial is failed to produce an overall survival. So we need to wait till the overall survival data come from this ADAURA. Next. Next. So these are all about my presentation. I need to conclude with this with this discussion, that regarding chemotherapy, we have to give chemotherapy for all non-small cell lung cancer patients, even with the complete R0 resection from stage 2 to onwards. For 1B, if there is more than 4 centimeter size, we should give chemotherapy. Regarding radiation therapy, after the ART-LUNG trial, there is no scope for radiation therapy even with N2 disease. Only if there is a R0 resection, R1 resection, then we could consider radiation therapy. Immunotherapy, still we need to wait till the PARS or ETOP trials give us the result. Regarding TKI, though the CTONG and ADAURA gives a very good disease-free survival rate, but the overall survival data is still missing. So we have to wait regarding this TKI therapy as adjuvant therapy. That's all. Thank you.
So thank you, Sumon. I think it was quite informative. Sorry for the initial interruption for the technical issue, but I think it was fairly covered about the historical perspective of adjuvant chemotherapy, how it evolved with the ANITA trial, the very landmark trial, which really established the role of adjuvant treatment and also distinguished which group will be benefited and which not. And then you have nicely covered the port role and the very recent update in the ESMO that N2 is no more a candidate for port. And finally, the confusion about the adjuvant TKI, I think it was fairly clear, but still we appreciate there must be some question, and without question, discussion will never be complete. So I see no good question in the chat box. So may I request anybody to unmute yourself and ask the question. No question? So there are students, there are mid-levels, and it is a very tricky area, this adjuvant treatment of lung cancer, because sometimes we are doing overkill, sometimes we are not doing justice to our patient. I think this is a gray zone for lung cancer. It is not a straight cut zone where we give the locally advanced or metastatic. Adjuvant is a gray zone where sometimes we are doing overkill, sometimes we are doing injustice. So I think there should be some discussion. I shall appreciate if there is some questions. So let me start the question to Sumon. So we see the Sitong trial, there Gefitinib had a wonderful DFS, but finally it failed to show OS. But Adora is making really good noise. And even they have recommended to do a interim analysis at the end of 2020 to look at the OS. I mean, because they are seeing so much separation of curve. So as you have gone through both the study in details, do you think that we are going to see some difference in OS also there, or what do you think? What is your expectation? I'm just wild guess.
Okay, actually, this issue was just discussed in some series. What we are expecting in the Sitong trial, they have tried Gefitinib. This is the first generation, and you could see that after the Flora trial, you could easily understood that osimertinib is the better drugs even in first line setting, because it has the CNS activity. So as the osimertinib is a better drugs compared to Gefitinib, and it has a potential role in CNS metastasis. And here they have included 3 years comparative to Sitong 2 years. You can see that the more than 90% disease recurrence occurs within the 3 years. So here in the Adora trial, they have tried to cover 3 years adjuvant TKI. So I think something positive might come out in respect of overall survival, but we have to wait. Till date, we can say what is really waiting for us.
My another question is regarding the adjuvant radiotherapy for margin positive. What is the what is your take on the target of port?
So that is the bronchial stamp. That is the bronchial stamp where you could see you could find out the positive margin, and that is the bronchial stamp you can include it. That's all, because earlier trial we have tried to included the whole of the mediastinum, but after the Heartland trial there is no role, so we can only consider the bronchial stamp.
So, but when we are
Sumon, এটা কি পোস্ট অপারেটিভ আরটি হবে না পোস্ট অপারেটিভ সিসিআরটি হবে, বা কেমোথেরাপির পরে আরটি হবে? এটা কেমন? হ্যাঁ, ইন কেস অফ মার্জিন পজিটিভ যদি হয়, পোস্ট অপারেটিভ শুধু আরটি হবে না পোস্ট অপারেটিভ সিসিআরটি হবে, না আগে সিটি পেয়ে তারপর শুধু আরটি হবে, কোনটা হবে?
এটা ডেফিনিট এটার আসলে কোনো ডেফিনিট গাইডলাইন নাই, কারণ আপনার যদি পজিটিভ মার্জিন থাকে দে হ্যাভ অ্যাডভাইস ফর রিএক্সেশন। আপনি যদি রিএক্সেশন না করতে পারেন দেন আপনি কেমোথেরাপি এবং স্টাম্পের জন্য রেডিয়েশন থেরাপি দিবেন। এটার জন্য আসলে ডেফিনিট কোনো কিছুকে বলা নাই এইভাবে। At least
let me supplement Sumon, Asmapa. The
জি।
answer is, first of all, adjuvant chemotherapy. It is there. So we need to add radiotherapy when there is a margin positive. Initially, N2 disease, only margin positive. Next question is, so whether it is sequential or concurrent. So there was some study, they have shown that concurrent is giving additional toxicity without showing much benefit. So previously it was recommended that it should go sequentially, but now it is said you can go concurrent, you can go sequentially. There is no hard and fast recommendation, you must be concurrent, but it must be sequential. But you need to give both radiation and chemotherapy when there is a positive margin. And another question is regarding the stamp, Sumon. If it is N0, stamp positive, will you take any high risk node, or you will take only the stamp?
No, there is no prophylactic, there is no role of elective nodal irradiation.
It is not ENI. If it is IFI, that is, involved field irradiation.
So it is, if it is stage 1, there is N1 or N2. Which stage you are considering about?
Say it is a margin positive with N2.
If it is margin positive N2,
there is an interesting paper.
Yes.
It is by Chris Kelsley, 2006. They have published in International Red Journal. It is a very interesting paper. They have shown that on right-sided lesion, the ipsilateral mediastinal nodal chance is high, but on left-sided lesion, the chance is more. And they have shown that which location, which group of nodes you can take as a high-risk group. It is not total mediastinum. It is not ENI. So this is an old paper, but this is a series of pattern of failure they have shown. And till now, this paper is used for the oncologists to take some idea. They are not telling that it should be totally followed, but I will request our students especially, they should read this paper. They can take a note. It is a paper by Chris R. Kelsley. We will maybe send it by email. It is a Red Journal paper. We have the whole paper. It's very interesting. And they have shown how to decide the port. But the main problem, as Sumon was telling, for the student I am telling, the stamp is the more important part. We need to go to the image, vertical section, find out where was the bronchus, and then we need to find where it was cut. And that area with margin is to be irradiated. That is the main message. Not the mediastinum, not the elective nodal irradiation, not the whole node, because it is not giving survival benefit, but on the left side, it is giving more cardiac toxicity.
Right.
I have a question.
Yes, please.
Sir, considering the ERA trial in lung, there is no survival benefit, but still there is some benefit regarding the recurrence. There is some decreased recurrence in the radiation group. And we have seen in many malignancy, radiation only improves local recurrence, not overall survival. So why should we avoid radiotherapy in adjuvant setting in lung cancer, as it's
so Altaboshan here, there was a long debate with the radiation oncologist tried to grasp our subject as for the N2 disease. So at least we can offer some benefit for the N2 disease. But after the ART-LUNG trial, the debate is over, because you can see that in ART-LUNG trial, the mediastinal recurrence reduced around 50%. 50% mediastinal recurrence was reduced with the port. But when you come to see the overall survival after giving port, it quite reduced the only observation group. So here we are not seeing only the locoregional recurrence. Our main objective is overall survival. And this reduced overall survival comes from this radiation therapy causing cardiopulmonary toxicity. So finally they concluded that, so it is not a hard and fast rule. So there is not saying that you don't give any radiation therapy. So it is your judgment. So where you are going to give, in a sense, in a broad sense, that the post-operative radiation therapy, even in N2 disease, is not very beneficial.
My question is, because maybe there was 2% benefit, 2% less overall survival in the PORT group, but was it statistically significant?
No. That was not.
That's why I do this question, because in breast cancer, after lumpectomy, radiation only improves local control, not overall survival. So why we
No, no,
But
no,
back there.
but in Oxford review, it has been shown that if we prevent 4 local recurrence,
for breast cancer.
Hello, Lima.
so it is for breast. If we,
Yes.
if we prevent 4 local recurrence, then we can prevent 1 breast cancer death. It is the
Okay, Lima, the answer to your comment is you are very correct that in breast cancer, this is the meta-analysis for the local recurrence and overall survival. So they have said 4% over local recurrence can be translated to 4 to 5% can be translated to 1% overall survival because there was no OS data. But here, when we are having both OS data and local recurrence, and we are finding that there is reduction of local recurrence but no OS benefit, then we can argue that shall we give or not. But in breast, we didn't have any OS data. That's why that meta-analysis, EBCG meta-analysis, they have said that, may I say mastectomy, radiotherapy, post-mastectomy radiotherapy, 20% reduction of local control. There is no direct overall survival benefit, but we say it can be translated to 5% survival benefit. Similarly with Oxford analysis. So in breast, as we didn't have OS data, and it was contaminated by cardiac toxicity. So we argue on breast on local control, but in lung, there they have shown that we are achieving local control, but it is not local control, it is it is medicinal control. But end of the day, we are getting not OS benefit. So our main target is always OS. If we don't have OS, then we go for DFS, we go for local control. That's why here, Adnan, as there is finally OS could not be, we don't see a OS benefit. So there is no strong recommendation, but it is your call. If you feel you can, but it is not a strong recommendation.
So Sumon, a very wonderful and informative presentation. So thank you so much. So my question is, based on this lung trial, which was published in 2020, should we equate this port into disease from tomorrow? Should we change our practice? Because still in the NCCN guideline 2020, port is indicated is an into disease for adjuvant. So can we change it just from tomorrow based on this lung trial?
I think we should change our practice because this Artlang trial was a very awaiting trial. We all the radiation oncologists were wait for this result because there was a long debate regarding this port. So whether the meta-analysis, the old version was tried, I have already mentioned. But after this port, Artlang trial, it is clearly stated that there is no difference. So why to give overburden to our patients where that is not going to produce any overall survival, rather it is going to produce cardiopulmonary toxicities.
Yeah, it is even worse. No,
Yes,
52 versus 58%. Yeah.
So Lima, we can say that, always there are some trial which is a practice changing trial. And as Sumon was telling, the port is a most controversial part of adjuvant lung cancer management. And it was a big debate. Initially, you can remember it was ENI. Then they have changed from ENI to no ENI. Then they have come to IFI. Then even they were not very sure about this nodal issue. Finally, this Artlang was the awaited trial, which is published with the mature data. I'm sure the next version of NCCN will change it and they will delete the N2. So for today, our take-home message will be that we should, of course, give port for margin positive, but we will think twice before considering N2 disease, N2 and above. And yes, as Sumon said, it is the clinical judgment. End of the day, if I am not comfortable, maybe, but I should think that whether I am buying any benefit or I am causing some harm to the patient. Because you see, if you look at the data of breast, I'm coming back to breast. Initially, people were very scared about the outcome, but finally they found out the big number of death was due to cardiac toxicity. It was not for breast cancer. So the survival of breast cancer, they have rewritten after taking out the cause of death from cardiac cause. So 10 years back, the cardiac toxicity by radiation was not a big issue. Now everybody is very concerned about cardiac toxicity. So in breast, in lung, heart became a big player. And now they have found out that cardiac toxicity is the reason for not getting the survival benefit. So that's why I think we can safely skip N2. Here, I want to mention one interesting thing. I don't know whether you have noticed that adjuvant durvalumab was 2 weekly. Last 3 days back, FDA has given an approval of 4 weekly protocol of 1400 milligram fixed dose. So the life of the patient will be easy, no more 2 weekly dose and fixed dose of 1400 milligram, which was used for bladder. They have approved it for lung. So non-small cell lung cancer is stage 3 after chemoradiotherapy, no progression, stable disease. We can still go for 1 year, but not 2 weekly, but 4 weekly, 1400 milligram fixed dose. Another point I want to address that I have seen some decision which was quite alarming, that many of our colleagues, we are now very practicing core biopsy in lung cancer. And as a result, we are getting the molecular mutation test report. But surprisingly, we have started giving TKI in non-metastatic setup. Because I think the moment we have the molecular test report in our hand, it gives a temptation that we should TKI, which is quite dangerous. And I was asked by one of my colleagues to use concurrent TKI in locally advanced lung cancer. So this is a message that till now, other than metastatic setup, there are many studies going on to try with SBRT, try with concurrent, try with adjuvant, but no mature data of oral TKI in any form other than metastatic. So this is, even we have all the mutation positive, but we should not be tempted to use TKI in non-metastatic setup. This is a very alarming thing. I have seen quite a few prescriptions and I was quite scared that whether we are going in the wrong direction. Yes.
Is there any indication of doing this biomarker testing in non-metastatic setting?
No. The problem is what is happening. We said that don't do FNAC, do core. So what people are doing core biopsy, and at the same time they are doing the molecular testing.
Even
so
if it is not metastatic.
Yeah. So if it is an adeno, if somebody is doing it, I don't mind. For example, say I have the information. But the problem is the moment I have the report, then I am tempted to start either osimertinib or crizotinib. I mean, whatever the positive is there. So that is the problem. So once you have something in your hand, I forget that it is not a metastatic. So that is the message I want to share with our colleagues, that it is not mandatory to do the molecular testing at the beginning. Number one, if it is not metastatic, even you do, no problem, but you should not use it unless and until it is a metastatic.
But can I use it in later,
Yes.
When the patient comes with a liver swell or something like
that.
That time, can I use this biomarker testing
you can.
Did previously?
Yes, you can.
Sir, regarding this issue, if patient is if core biopsy is done and molecular testing is done in the non-metastatic setting, and we found it's like EGFR or ALK positive, something like that. But after giving the treatment like radiation or chemotherapy, should the receptor status will be the same at when the patient progress or presented with metastatic disease? Should we use it again, or should we do core biopsy again?
If you have the primary tissue, we can use that. There is like breast cancer, it is not recommended that you need to do it again. But if it is EGFR positive, then if it is resistant, then you can do T790M for second line. But once you have, if you have something from the first tissue, you can do it. It is not mandatory that you need to do for the metastatic lesion. It is not expected that it will lose it. Sumon, any comment?
আমি কামাল ভাই আউট আমি কি ছিলাম না, আমাকে কোশ্চেনটা যদি আবার একটু করেন।
প্রশ্নটা হচ্ছে নন মেটাস্ট্যাটিক একটা পেশেন্টের কোর বায়োপসি করা হলো, করে তার টিস্যুটা রেখে দেওয়া হলো বা মিউটেশন টেস্ট করে ফেলানো হলো, রোগীটা ট্রিটমেন্ট করার 3 বছরের পরে মেটাস্ট্যাটিক হইলো, তাহলে আমরা কি আগের টিস্যুটার থেকে কোর বায়োপসিটা টিস্যুর থেকে কি আমরা করলে কোনো ভুল আছে কিনা বা আগের টেস্টটা ইউজ করলে কোনো সমস্যা আছে কিনা?
না, কোনো অসুবিধা নাই।
আমিও জানি, তাই আমি যেটা রিকমেন্ডেড হচ্ছে, কারণ সব সময়
টিউমার গুলো সাধারণত হেটেরোজেনাস দেখা যায় যে মেটাস্ট্যাটিক সেটিং এ যে এগুলো ডিফারেন্ট টাইপের এক্সপ্রেশন করে অনেক সময়।
এটার আনসার হচ্ছে তোমার যদি
প্রত্যেকবার মেটাস্ট্যাটিস একবার করে বায়োমার্কার করতে হবে।
এটার আনসার হচ্ছে ইউ ক্যান হ্যাভ দ্য বেসিক মিউটেশন, তারপরে যদি তুমি কাজ না করে দেন ইউ ক্যান গো ফর এনজিওস ফর লুকিং ফর মোর, বাট এটা চেঞ্জ হয় না। এটা হ্যাঁ,
আমি একটু ক্লিয়ার করি, সেটা হচ্ছে যে আমরা
Shumon bhai,
হ্যাঁ,
we should speak in English because we have a foreign participant.
Okay, sorry.
Okay, the issue is regarding the tissue biopsy, we are consideration for the genetic mutation, right?
Yes.
The genetic mutation usually is not changeable, right? The ERPR HER2 status for breast cancer. So for the early stage, after the surgical specimen, if you have the specimen, you could find out the driver mutation status from there. So there is no harm.
From the tissue, we can find the not germline mutation. This is the somatic mutation from tissue.
Yes.
Right.
Yes.
And from blood, you can find this germline mutation.
No. For the lung cancer mutations, there is no germline mutation. It's all are somatic mutations.
So Lima, to answer you, that say for example, what we do 5 tests. Standard is recommended 5 or 6 tests. But if we are having a problem with a patient and even we are exhausted, then maybe
I missed the part.
So say for example, we have a tissue and we have done 4 or 5 tests, EGFR, AG, LOS, BRAF and MET and PDL1, and we have exhausted. Then we can look for further mutation from the metastatic site or for the resistant site T790M or anything that whether we can, but as Sumon said, like breast, ERPR change, it is not change. EGFR once positive, it is normally with time, it is not going to change.
But there is another issue we could consider for the PDL1 expression. That is another chapter. Here there is some difference you could find to whether to find out this PDL1 status from the primary disease or from metastatic disease. But there you could find some difference. But for the genetic mutations, you can easily done from this previous tissue sample.
So I think, Sumon, we had a wonderful discussion, and thanks to all the participants for taking part. Yes, please. Yes, please.
Thank you, Sumon bhai, for a very fine presentation. So my question is, we are giving post-op-RT to positive margins. What is the negative margin we should achieve?
Sorry, I am not clear.
What do you mean by negative margin? What is the distance? It is 1 millimeter, 5 millimeter,
5 millimeter or 1 centimeter.
So we could. I really not really not know the answer clearly. So
okay,
what is the margin?
Answer, Debra. Hello.
Yes, sir.
In TNM staging, there is 3 terms. One is negative margin, one is closed margin, one is positive margin. So standard is 1 centimeter is the clear margin up to 0.5. If less than 0.5 to 0, it is near margin, and it is when it is positive, it is positive. So this is with some exception like sarcoma. So here you can say that if it is 1 centimeter, it is fine. Up to 0.5 is, if it is less than 0.5, it is closed margin. That is the recommendation.
So sir, we should give post-op-RT to close and positive margins both, right, sir?
Yes.
Right.
Yes.
So is there any option of resection, sir?
Of course,
Definitely.
any malignancy, not only lung, in the whole body. If there is any malignancy, if there is a surgery, if there is a positive margin, first option is resection. If the surgeon agrees to do the resection, that is the best thing. If it is not, then we do the port.
Thank you, sir.
Regarding the margin, which site or tissue we consider for margin? Bronchial stump or lung parenchymal tissue?
Bronchial stump.
Stump.
Yes, sir. And sir, regarding toxicity, to Sumon sir, what was the toxicity status of the patient after chemotherapy? Which kind of toxicity was higher in chemotherapy group?
It depends the which chemotherapy regimen you are going to give. It is depends on the chemotherapy, because you know that every chemotherapy has a specific type of toxicities.
Yes, sir. So is there any contraindication of chemotherapy in cardiac patient with cardiac comorbidity?
Absolutely. There is a simple rule of thumb. If you have patient with ejection fraction less than 50%, so you can see that the insistence that the NICE guidelines that they have mentioned that performance status more than one, if the performance status is more than 1, you are not going to give chemotherapy.
Yes, sir.
Here the same, the ejection fraction less than 50%, you are not going to give chemotherapy.
Thank you, sir.
So I think we had enough discussion. Now we move to the case discussion. Thanks, Sumon, for your presentation and answering all the questions and enlightening us with the information. And thanks to all the participants who has taken participation in the discussion. And that is the heart of the program. Presentation is the initiator. So we always appreciate that there should be, good interaction. So before moving to the case discussion, I am looking at that. There is a question that more than 2 centimeter is preferred for parenchymal. They are telling that for lung. If it is a parenchymal margin, when they go for it, it should be more than 2 centimeters. So we move to, and if we have some more information on this, maybe we will discuss on the next week. So now I request Arman to go to your case presentation, case discussion. Arman. Dr. Arman Chaudhary, who is a consultant in Delta Hospital, and he will be doing the case discussion today. Dr. Arman Chaudhary.
Kamal Bhai of Delta, na?
Thank you, Dr.
Kamla, not Kamal.
No, কিন্তু কামালই লিখছে প্রথমে।
Thank you, Dr. FM Kamaluddin Bhai, for giving me the opportunity here to present a case in this academic platform. And after the presentation of Dr. Mostafa Aziz Sumon Bhai, actually it is easier for me, because most of the studies, or what we do actually during our case presentation, after side by side we give some evidences or show some evidences, and most of the evidences is already presented in the presentation of Dr. Mostafa Aziz Sumon Bhai. So it will be easy for me, and it will definitely it is a boring situation for you people, because you have to see the evidences again and again in my slides also. So I just want to skip, or we'll go first with this. So regarding case presentation, what we do actually, we take a volunteer. We take a volunteer for our presentation. So who will be the volunteer for my case presentation? We have some students here, some residents here. So who will be the volunteer? If anyone interested, you can show your interest. Otherwise, I think Dr. FM Kamaluddin Bhai will select. One volunteer is needed.
Lima, nominate someone.
Yeah, Lima, you please nominate someone.
Taslima Hossein কে? নওশীন তাসলিমা হোসেন নতুন। নওশীন তাসলিমা হোসেন কে? নওশীন তাসলিমা হোসেন নতুন। ওকে কল করো।
Are you here? Naushin Taslima Hossein, Dr. Naushin Taslima Hossein. I'm not seeing him. I'm not seeing her now.
Assalamu alaikum, sir.
Yeah. So, would you like to be the volunteer today?
Sir, I'm not sure.
Definitely you can. You just proceed.
Definitely you can. You just,
if there is a problem, we will support you.
Definitely. So, can I start, Dr. Naushin?
Okay, sir.
Okay. So, I'm sharing my presentation. So, I just want to start my case, and this is already Kamal Bhai introduced me. So, is it visible?
Yes,
Yes,
Arman,
sir.
visible.
Okay. So, my case, 55 years old gentleman, smoker, 15 pack year, diagnosed with a 6 centimeter spiculated right upper lung nodule. So, true cut biopsy was done from that nodule, and it was adenocarcinoma grade 1. So, staging investigations done, and it revealed no evidence of distant metastasis. So, he underwent right upper lobectomy, and surgical pathology report indicated it was pathological T2B, N0, and MX, well differentiated lung adenocarcinoma. And surgical resection margins were negative, and there was no vascular invasion or neural invasion. And the stage was stage 2A. So, Dr. Naushin, how do you proceed for further treatment? What is your opinion? What should be the adjuvant treatment for this patient? What do you think?
In case of T2B, I'll go for observation, as there is negative margin. I'll go for observation.
Very good. So, this is the evidence. It is from 2020 NCCN guideline, and you correctly said that as margin is negative, you will go for observation. But there is a role of chemotherapy for high risk features or high risk patients. So we have to know what are the high risk features. And if we want to see this, I have highlighted these high risk features from NCCN guideline, that grade 3 histology, neuroendocrine tumors except the grade 1, lymphovascular space invasion, weight resection, tumor more than 4 centimeter, visceral pleural involvement, and unknown lymph node status. These are the high risk features. So what do you think? We should give some chemotherapy or not here in this patient?
So as T2B, so it's more than 4 centimeter.
Yes, that is the point.
So we should give him chemotherapy.
Very good. So there was a high risk feature that is more than 4 centimeter size. It was 6 centimeters. So we should give some chemotherapy. So think if the margin comes positive. I already mentioned that margin was negative, but if the margin comes positive, then what will you do?
If margin was positive, then I have to say whether it is R1 disease or R2 disease. In case, preferably is resection and chemotherapy.
Very good, very wonderful answer. So it is also from the NCCN 2020 that if the margin is, if the margin is positive, then we should go for resection, which is the preferred option, and followed by chemotherapy. And if the resection is not possible by any means, then radiotherapy plus minus chemotherapy is the option. So now let's change the scenario. The surgical pathology report indicated that it was a pathological T2B, but the disease is N2 disease, and histology was same, grading was same, and margin was also negative, and due to the N2 disease, it becomes a stage 3A. So what is your option for this scenario?
Sir, I will go after surgery. Though in case of in a recent NCCN guideline N2 disease, they said that to give radiotherapy, but Sumon sir has said that recent trial, Langa trial, they have said that without post-op radiotherapy, 3-year overall survival is 68.5%, and with RT, they have said 60.5%. So there is no role of post-operative radiotherapy in N2 disease. I'll go only for chemotherapy.
Okay, so let's see the scenario.
Resection and chemotherapy.
Evidences. So you have correctly mentioned that regarding this N2 disease or regarding this sorts of scenario, you will give chemotherapy. And already in NCCN guideline, they mentioned that to give radiotherapy in case of N2 disease, but now the new publication has come, that lung-RT trial. So I will discuss this. So let's see some evidence regarding concurrent versus sequential chemoradiation in completely resected pathological N2 non-small cell lung cancer. It was published in Thoracic Oncology in 2000. Nearly 2,000 patient was analysis, and they found that there was the difference in median overall survival for about 16 months. In case of sequential chemoradiotherapy, it was 53 months, and in case of concurrent chemoradiotherapy, it was 37 months. And patient receiving concurrent chemoradiation therapy compared with sequential chemoradiotherapy had a 35% increase the risk of death. What we actually want to mention that concurrent chemoradiation giving some added toxicities, and it increases the chance of death, as well as it decreases the median overall survival. Another paper published in Lancet Oncology in 1998 is an old paper. They also concluded with their paper, it was actually a meta-analysis of 9 randomized trials, and they concluded that postoperative radiotherapy is detrimental to patients with early stage completely resected non-small cell lung cancer and should not be used routinely for such patients. So we have to remember that factor, like it was early stage and completely resected non-small cell lung cancer. And the role of postoperative radiotherapy in the N2 disease, they told that it should be, the further research should be warranted. So now in the case, think it was stage 3 disease, and cytologically or histologically the node was positive, and patient received neoadjuvant chemotherapy. Okay, then after that he underwent complete resection. So after neoadjuvant chemotherapy, then surgery, complete resection, what is your next plan? It is N2 disease, and neoadjuvant chemotherapy given, and then resection, complete resection was done. Will you go for radiotherapy, or will you go for chemotherapy?
Sir, I will not go for radiotherapy.
So I just want to arise this scenario as because to see highlight the lung-RT trial. Already Dr. Sumon already mentioned it was the hot talk in ESMO 2020, and already it is entirely discussed in the discussion. So disease-free survival not significantly statistically significant with the addition of port, and regarding overall survival in port arm it was 66.5, and without port it was 68.5. So and others already mentioned. So the recommendation from the author is postoperative radiotherapy cannot be recommended for all patients with stage 2 and stage 3 non-small cell lung cancer with mediastinal nodal involvement. Not all patients, but possibly some patient it might benefit, it might get some benefit because it does not decrease the rate of mediastinal relapse by 50%, but this must be put into the balance with the risk of overrated cardiopulmonary toxicities. So evidences behind chemotherapy, already Dr. Sumon mentioned this BMJ 1995. I don't want to mention this cisplatin based analysis, which gives absolute survival benefit of 4.1% in adjuvant setting at 5 years, and this JBR10 strongly discussed. And this one is also a paper which was published in 2008 in Journal of Clinical Oncology regarding the use of paclitaxel and carboplatin versus observation in stage 1B, and they also mentioned that it is needed in if the tumor size is more than 4 centimeter. It is also presented by the original trial. It is also presented by Dr. Sumon, and we already have seen that in case of stage 2 and stage 3, it gives benefit with the addition of adjuvant chemotherapy, and also the less pooled analysis was described or mentioned, And also we can see that regarding the stage, so stage by stage, the result of less pool analysis. So which chemo regimen should we give? This should be all. This is also discussed that the cisplatin vulnerable mostly studied in used regimen. Carboplatin can be used, but cisplatin is not comparable with carboplatin. But we have to use sometimes. And that is, regarding the timing, it is also mentioned by Dr. Sumon that the adjuvant chemotherapy should.
Aman bhai, you have.
Am I audible?
Yes.
Hello.
Yes, bhai, you are audible.
Arman, continue, please. Arman.
Sir probably got disconnected.
Okay. Samir, give him a call.
I'm calling, sir.
আমার ভাই সবাইকে দেখে আমার রোগে ধরছে।
সংক্রামক, সঙ্গ দোষে লোহা ভাসে।
আমি তো প্রথমে লজ্জা পেয়েছিলাম, শুধু আমি একাই বুঝি, এখন দেখি সবাই।
Hello. Am I audible now?
হ্যাঁ, আরমান শোনা যাচ্ছে।
Okay, I just lost my connection somehow.
আপনার রিপোর্টটা যেহেতু এসেছে,
So
আমরা চাই প্রথমে আমরা কেমোথেরাপি দিতে চাই।
আজকে তো শুধু বিভ্রাটের দিন মনে হচ্ছে আজকে।
Yes. So already I have mentioned, already Dr. Sumon also mentioned about the timing, and in case of EGFR positive. Yes, Dr. Noshin, are you here?
Yes, sir.
Okay, because I was not here because I lost my connection. So if this is a case of EGFR positive, because we know already Dr. FM Kamaluddin also already mentioned that what is our practice actually? What is the standard practice? The use of EGFR or whatever, the use of TKI is only in the metastatic setting. But
Metastatic settings. Yes, sir.
if after the surgery we can do the EGFR testing, and so if in this case the EGFR is positive, do you change your
Sir, I will not change my treatment as it is not a case of metastatic disease. Hello.
আরমান ঠিক আছে, প্রসিড করো।
Yes, Dr. Noshin, if it is EGFR positive, then what is your plan?
My plan will be same as it is not a metastatic case, so I will not go for TKI.
Okay, but the ADORA trial, what Dr. Sumon also mentioned, that in case of completely resected stage 1B, 2 or stage 3A non-small cell lung cancer with negative margin, prime, also the adenocarcinoma and EGFR mutation in exon 19 deletion and L858R mutation. So in this situation, we can go, the study was done in ADORA trial, that osimertinib versus placebo, and the primary endpoint was investigator assessed disease-free survival in stage 2 and stage 3A disease, and secondary endpoint was disease-free survival in overall population. And here we can see the result in case of stage 2 and stage 3A, in terms of disease-free survival, osimertinib gives a very excellent result, and in the case of overall population disease-free survival, it also gives better results, and the progress curve is also showing in favor of osimertinib. So the investigators concluded that adjuvant osimertinib should be incorporated into the standard practice for treating patients with stage 1B, 2 or stage 3A EGFR mutated non-small cell lung cancer following the complete resection. So these guidelines already mentioned by Dr. Mostafa Aziz Sumon. But the ESMO recommendation, I just want to highlight because it was not presented by him, that adjuvant chemotherapy should be offered to patients with resected stage 2 and stage 3 non-small cell lung cancer and can be considered in patients with resected stage 1B disease and a primary tumor more than 4 centimeter. And always, it is for always that this type of cases should be discussed and the decision should be taken under the multidisciplinary tumor board. That is very much important. So before ending my case presentation, thank you, Dr. Naushin. I would like to thank you. You excellently you perform here. And the Oncology Club, we know that it is the dream, and the founder of this is our Professor Dr. Karim sir, ABFM Karim sir. And after that, now it is running with the great two peoples, Professor Dr. M. Hai sir and Professor Dr. A.M. Fredul Alam sir. They are the umbrella of us. And after that, I should mention that this person, the Scientific Secretary of Oncology Club, with his initiative, actually, we are doing these sorts of seminar. The last few days ago, we have completed our 3 days breast virtual conference. So I should salute and thank these people, this person, and I should say Allah give him long life so that we can do these types of program in future more and more. So thank you for your presence here. Thank you.
Thanks, Arman. It was a wonderful case discussion, and except the last part, I think it is quite appreciable. So, you know, this is, yes, it is a dream of Karim sir. We are under the leadership of Hai sir and Sharif sir, but it is no single person. All these things is a teamwork, and the team is working. No single person is working. So still, thanks for appreciation. I think now we are almost at the end of the session. Now we will go for our most awaited quiz session. May I ask Samit to put the quiz link in the chat box so that we can go for the link is given. Yes. Let's count the time. So during this period, if somebody have something, we can have some chit chat among ourselves. It is the floor is open.
Hello, everybody. My name is Csongor Lengyel, calling you from Hungary, Europe. Can you hear me?
Yes.
Yes, yes.
Thank you, Dr. Arman, for inviting me, and I really enjoyed the conversation. I am biomarker and molecular oncology fan, and I didn't really want it to hijack the meeting, but I have 2 comments regarding the adjuvant part, and that for ALK-altered patients, we are going to have soon some data from the Alchemist study that utilizes crizotinib in the adjuvant setting. And point number 2 is there was a very interesting subgroup analysis of the JBR10 adjuvant chemotherapy trial, which showed that overexpression of P53, these patients were more deriving a benefit from the adjuvant chemotherapy. And that was really interesting. I can share the link if
so we should do the P53 routinely.
That is just, I think, a food for thought. But I don't think it's it should be a routine test. But because in the same ASCO presentation, which was in 2012, they also showed that the KRAS mutant patients were less likely to respond or benefit from adjuvant chemotherapy. And later there was a bigger study from 3 different trials from the same author, and he proved that KRAS was neither predictive, neither prognostic for adjuvant therapy benefit.
So thanks for joining with us. I appreciate the initiative of Arman. On behalf of Oncology Club, we are very happy to have you with us. So it gives a flavor of international meeting than a national meeting. And what you said is quite interesting because, you know, so many things are happening around the globe. And as you mentioned, and you responded to Shahida, that this type of observation is sometimes very exciting, but end of the day, it may not end up with a conclusion. You are very correct. But I agree with you that in the different part of world, people are now trying with this biomarker, trying to bring this up, all the TKI at many setup like new adjuvant, concurrent, many setup. But as you understand, it is a discussion we are doing for the mid-level and especially the juniors. So we try to stick on the strict recommended guidelines, because if we bring these debatable issues much, they may become confused. So
Sure. Okay,
we discuss these things very. I appreciate the discussion, but always we try to stick that. Well, we should know what is happening, but it should not be a temptation for us to jump into this type of thing, because it should be very clean-cut designed study. Otherwise, this type of thing should not be practiced. But I am very happy to have you with us, and I should appreciate if you can join us sometimes in the coming days, because we will having some more session.
Thank you very much. Thank you. And I really appreciate to be here.
Thanks. Thanks, Arman, for bringing the international participants to make the program international. So I wish that your invitation will be valid even when your performance is not there.
Definitely.
So I think we are almost at the end of the 5 minutes. So we are counting down 40 seconds, 39. And with the quiz session, we don't have any rapid fire session today, as we have enough discussion. We will end up. And Sumon, who will be the next speaker next week? Do we know that?
Let me check. I have to check. I will inform tomorrow.
But there was we need to explain that we made a discontinuation of our program for last 2 weeks due to the breast cancer conference. But inshallah, now onwards, it will be every week we will be doing. And hopefully the participation will be regular, and we will be having more programs. Another announcement that on 19th and 20th December, we are going to have a preceptorship program on colorectal cancer. The formal flyer will go to everybody for registration, but just for advanced information, we will have 3 wonderful faculty: Dr. Alessio Morganti from Italy, we will have Senthil Rajappa from India, and also Dr. Sumit Goel from India. So these 3, and we are looking for some additional faculties to design it, but it will be exciting session on preceptorship, and I will appreciate if you all get registered and ask your friend to get registered. So the quiz is over. If we have the result, we can declare the result, and then we can slowly wrap up the session, because it is 10:37. I may try to show the result of the quiz as early as possible so that we can wrap up. Yes, so we have the result, and there is no surprise. This gentleman has developed a habit of winning the quiz, and that is Dr. Altaf Hussain Ria. Congratulations.
Thank you, sir.
Still, the score was not very good. It was only 70. So the question maker, Sumon, was quite tough.
Sir, I think these issues have been discussed repeatedly.
So our main objective of all this discussion is to repeat the basic things so that we don't make the common mistakes. And we want to send you some messages, and that is our objective in different format, by question answer, by case discussion, by quiz, by lectures. Our bottom line is to send some messages to our colleagues, and if we are successful, we'll be happy. So with this, I think we can now end up the session. Sorry?
কত % কারেক্ট করছে?
70.